Good evening, everyone, and thank you for joining us for tonight's clinical webinar, PENTACAM Technology Turning Non-Candidates into Candidates. Our speaker this evening is Dr. Arun Gulani. Dr. Gulani is former Chief of Cornea External Disease and Refractive Surgery at the University of Florida. He is also founder and director of the Gulani Vision Institute in Jacksonville, Florida. Dr. Gulani has published numerous studies in both U.S. and international journals, as well as countless articles in periodicals like iWorld, Ophthalmology Times, Review of Ophthalmology, and Ocular Surgery News, just to name a few of them. The Florida Times called Dr. Gulani Man of Vision. Forbes magazine listed him as one of the leading laser eye surgeons in the United States back in 2009, and those who are closest to Dr. Gulani call him Dr. GQ for his style and fashion. Luckily for Dr. Gulani's patients, his attention to detail, artistry, and passion are even more apparent in his work as a surgeon. On behalf of Oculus, I would like to thank Dr. Gulani for being here this evening and sharing his unique, customized approach to surgical vision correction. And before we get started, I would like to point out that you have a text box on the right side of your screen for asking questions, and I encourage you to ask Dr. Gulani questions during the presentation. We should have some time afterwards to get to those. And so at this point, without further delay, I would like to welcome Dr. Arun Gulani.
Well, thank you, Chris. This topic is very close to my heart, where in my practice, where I see a lot of second opinions and complications, I have found over the years that actually correcting them is not that difficult, and all we need is a mindset of trying to break down these complex situations into simple, understandable issues and take each patient to hematropia. So today evening, I'm not going to be going deep into the indices and the parameters of the PENTACAM technology, which are very well illustrated on the machine itself. And Chris, who is with me tonight, is an expert in that. But I'll be talking more about the mindset of using the entire spectrum of vision corrective surgery as an art, and how the PENTACAM can be used to its maximum potential in that process. For example, not only is the PENTACAM I use in my practice used for diagnostic purposes, I use it also for education of the patient, and that part I break into two areas. One is vocal, where you're speaking to the patient as you're showing the PENTACAM. Second is visual. Let them look at their cornea, the length, the relation, the optics of the eye, and then they get it, how a customized plan is being made for them. So let's go into the presentation right away. So most of these patients who are told they're not a candidate, the most common reasons are aberrated cornea. If you see, I'm trying to keep it very simple in the sense that a lot of terminologies can be used. Irregular cornea, cornea with scars, whatever. We just use simple terminology, so you break it down into a thought process. The most common reasons are aberrated cornea, patient has a history of multiple previous surgeries, and what I call self-paralyzing diagnosis, where a doctor gives a diagnosis which scares the doctor and the patient, and then the aim is not towards excellence. And finally, it's what I call does not make sense cases, meaning you look at the patient, you look at the papers they have with them, and you go, wow, this is just too complex. So these are the cases most commonly sent over as not a candidate. To me, everybody is a candidate. Of course, let's quickly get into the backbone for a minute and then come out of that is you obviously have to have this a lot of responsibility. There should be ethics, safety, no advertising, fluff, deals, or incentives, but genuinely believe in your mind that everybody is a candidate and they deserve to see the best they can, and it's our duty as an eye doctor to deliver that vision. So the mindset I want to stress on here is stop the train wreck. In other words, try to take the obstacle as an opportunity to think, to plan, to approach, and perform. So our main mindset over here is no matter what the patient is coming with, the patient must see perfect. Think about vision, not surgery. Don't go armed into the room of the patient with, I do LASIK, or I have to do this new lens implant that's come out, or I have to do this cross-linking that's just been released. Go in with an open mind, looking at the patient, and then break down their complex situation into simple. We'll see a number of cases tonight which I will share with you how we can break down all these complex looking scenarios into simple situations. And then plan of action should be done, as I said, by education of the patient, right there in the room, by the doctor. And that plan has to be visual and vocal so the patient gets it and becomes your team. Of course, like I said, safety, ethics, expectations, everything well controlled. The rest is our desire for perfection. The other mindset I'd like to talk about is the technology mindset. A lot of doctors keep sending me reports and printouts and saying, can I do LASIK on this patient? Can I do this on this patient? I keep answering that question by saying, don't go in with a surgery in your mind first. Look at the patient. The technology, including PENTACAM, we do not want to look at it as a robotic diagnosis, meaning just because you saw some indices or a parameter, you start panicking about, is this abnormal, normal? Does it fit into my group for, let's say, a LASIK surgery? Do I have to shift to another surgery? Look at the technology for data input. The way I like to talk and teach about these things is, just like in bowling, look at all the pins, count all the pins, lay them out, and then plan a strike. So similarly, pick up all the visual aberrations you can while you're looking at this technology with the patient in the room. And even they will understand that their case is complex or unique and how you're thinking through with them. Customize the surgical plan to reach maximum vision at all levels, no compromise. This is a very important statement. And you see that again and again in the cases that I will share with you, that the cases could have been done in other ways, but you wanted to maximize the vision with the least intervention. So as long as these two mindsets are clear, we can now proceed straight onto a case and jump in and see how we are thinking through. Now here's a patient, a 68-year-old patient, sent to me with his surgeon did an excellent pseudophakia, cataract surgery, but patient had keratoconus. So they had an IOL surprise. Well, the doctor went ahead and did a YAG laser after that. So the presentation was, this patient was hyperopic with astigmatism, a very superficial but central scar from keratoconus, of course high keratometry and thin cornea, and the lens now was in a bag that was open. Now when you look at the scenario, and the patient is frustrated because he's a very active guy actually trying for his pilot's license. So to him this was horrible. He was close to +2 with a -1.5 astigmatism, so he couldn't see distance or near. Now the surgery was well done. The surprise is a possibility, but you again have to go back to our mindset. How do we make this gentleman see with the least amount of surgery? So when I analyzed this patient and I picked up all my pins, as you can see in the topography below, the astigmatism is there. There's a central irregularity from the scar, and of course keratometry is high because of the keratoconus. Now, the one process I would like to use on this patient to get everything in my ball court for their best vision would be to flatten the keratometry, to remove the scar, to improve the central optical zone, and in the process, bring this patient to emetropia. Now, having picked and selected what I want, the one surgery that gives me all these things is myopic laser PRK. So I have a problem now. This patient is hyperopic. Now, a few doctors, when I was sharing this case with them and reviewing as we were teaching at the ASCAs recently, they said, well, we would have done a hyperopic laser PRK. Well, you can, but again, you're forgetting one of the principles that I stress about is maximizing the vision, not just taking them to good vision, but maximizing given the opportunity. So had anyone done a hyperopic laser, first of all, you're increasing the keratometry, so the quality of vision is poor. Second, you're not getting the central scar in this patient. And third, even though you got a good refractive endpoint, the quality of vision is not as great in these cases of keratoconus, and you raise the keratometry beyond accepted level. So with my desire to bring myopic laser on this patient, my goal became very simple. I sat down with this patient for an hour. I refracted him. I refract all patients personally, went to the PENTACAM with him. And I said, you know what, I want you to be myopic so I can execute everything I want. Now the patient forgot all his anger against his surgeon, and he got involved. He's like, well, doc, how will you make me myopic? So all his anger about his outcome, about his surgery, about where he had landed, about him having to travel to me from his surgeon, fizzled out as he came and became my team, and our goal was singular. How do I make you myopic? Now, when you look at his eyes again, we break down this complex scenario of post-keratoconic pseudophakia. Let's not use big words. Now, I want to somehow make him myopic, so I come about, all right, he's got a nice deep anterior chamber, good endothelial count, stable in his refraction. I can put in a piggyback lens. Remember, his lens, the bag was open. If his bag was not open, I would have exchanged the lens. Given this scenario, we put a piggyback lens. Again, corneoplastique, as I will explain to you, I have 5 filters in my brain. Every surgery I do must be topical, brief, aesthetically pleasing, visually promising, and least interventional. So every surgery I will talk about here and in my practice every day has to pass those 5 filters. So a piggyback lens, 5.5-minute surgery, we put a lens in his eye, topical, same incision as his previous surgeon, we do a peripheral iodectomy, and turn him into a myopic astigmatism, planned myopic astigmatism. Now we have him ready, and in a month, he was stable. I refract him again at 5 weeks, very stable to 2020. Now I do my laser PRK on him and bring him straight to 2020, flatten his keratometry with the myopic laser, increase his optical zone, and with the myopic laser, clear the central scar. So we got all our goals with another 4-minute surgery, and the patient is ecstatic because he went from good to perfect. Last time he sent me an email telling me his vision with his eye doctor now was 2015, better than 2020, and he got his pilot's license. So this case itself tells you, you could leave this patient alone, you could have done something on him, but how do we maximize vision in our own mind for such patients and take them to emetropia? Now, the PENTACAM, as you know, has so many screens and parameters that you can use it to your knowledge and also help the patient or educate the patient visually and vocally. You see here, you can show them in these overview profiles their entire cornea. For example, in this case, a scar. The intact that I put in this case to stabilize before treating the scar, lens is clear. Come to this area, I show this a lot to patients. For example, a patient may come in for hyperopic LASIK, but is 58 years old and has a shallow chamber, cannot see distance or near, and has early fuchs dystrophy. Now that patient, you rather do a lens exchange surgery, and the patient gets it. It doesn't matter what they came in for. It's important that we plan what's right for them. So here I would show them the lens, for example, show them the cataract exchanges. This is a deep anterior chamber. Over here you can see the corneal scar. This is the corneal densitometry preview of the PENTACAM, where you can actually see the depth of the scar and measure that. And then, of course, you have all these pattern recognitions by color in various windows of the PENTACAM. And the beauty, as Chris will explain, is also you have an area where you right-click, and it literally gives you a whole write-up on what that indices means. So the PENTACAM, I use it to give me direction, give me all the pins or all the data inputs I want. I don't really care so much for the diagnosis. So I don't fret over, oh, is this keratoconus, is this formless keratoconus, is this PMD? All that's great for my own academic interest in my mind. So when I'm looking at the patient, I'm looking at keratometry, patterns, profiles, thickness, lens relation to the cornea, lens clarity, the corneal regularity, corneal clarity. All these parameters once I've gathered, my mind starts working through my filters, and we are ready for action. Now, corneoplasty, as I've been talking about for 2 decades, is actually a mindset. It's a contemporary super specialty of LASIK, cataract, the entire spectrum of vision refractive surgery in making vision the accountable endpoint of all eye surgery by intelligently manipulating the optical interplay of the components within the eye to shape the cornea. And I call that vision rehabilitative platform by utilizing the laser. So if you look at this, we have over 48 different techniques that we can use right from the cornea to the lens and back. We are not yet talking combination to design for each patient for emetropia. The goals of corneoplasty are to raise vision outcomes beyond 20/20 in virgin eyes, to reverse practically any refractive complication, including LASIK, RK, premium lens implant back to 20/20. Turning patients are not candidates like scars, thin corneas, ectasias, regular astigmatism, irregular astigmatism, previous surgeries to appropriate candidacy, and applying the full spectrum of oculocorneal keratorefractive lenticular surgery. The principles, as I mentioned, was every surgery we do should pass through these 5 filters: topical, brief, aesthetically pleasing, visually promising, and least interventional. So the cornea now, we have 6 layers. The excimer laser to me is nothing more than an extension of our own precision at submicron tolerance. Let's go to corneal scars. Now, as you know from my work, I look at corneal scars as a refractive situation. And that's, again, a mindset. That's a paradigm shift. Don't look at the scar and look, here's the culprit, let me get rid of this, and let me then clear the cornea. I don't like that because that doesn't lead you to vision. Use the scar by shaping it. And I have hundreds of cases over 2 decades now where a well-shaped cornea, meaning emmetropic cornea, despite a residual scar, sees 20/20. So corneal scars, for reasons of explanation and sharing, I have taken over 48 to 50 categories of scars, and I've broken them into very simple categories: in cornea and on cornea. All scars, no matter what the cause is, infection, trauma, surgery, degeneration, dystrophy, whatever, all scars could either be in cornea, meaning they become part of the cornea, like in this case, and then the topography is real and the refraction is real. In these cases, I do straight away laser PRK based on refraction. And I refract every patient personally. And these patients can be taken straight to emmetropic vision, even if with residual scar. And again, they had a 4.5-minute surgery. Remember, all of these patients can have a transplant. The point is to keep it least interventional, visually productive. Here are in-cornea scars. Here you can see this surgical nurse we had, and this patient went to 2015. You can see the residual scar. Again, for argument's sake, these patients may not be as crystal clear as a virgin 2020 case, but given that they came from 2400 vision to 2015, they are thrilled with the vision outcomes. And again, remember, least interventional. So these are pre or in corneal scars. They become part of the cornea. Topography and refraction is real. Proceed straight to laser PRK, not PTK, straight to 2020. On cornea scars. Now, scars that are kind of above the Bowman's membrane, kind of lumpy and bumpy, you will see these scars creating a false topography. I call this the clown suit. Basically, I tell the patient, this is not the real you. I need to peel the scar, find the real you, and then design my surgery. So here you can see this topography, for example, is showing me 5.9 diopters of astigmatism, which is false. It's not real. And you can see in the densitometry picture how you can see the scar elevated. Here I am peeling away the laser scar, the scar in this patient off the cornea. In a resistance guided technique, always pull off the whole scar, don't take it piecemeal. Mitomycin application for 30 seconds, laser PRK, straight to clear cornea. So here's this patient in summary: on cornea scar, cleared, and then refraction which was false, bring them to clarity and measure them. Now, in this particular patient, 8 years ago, I peeled off the scar and brought him to 2020. And 8 years later, he was at the cataract age. This patient's original situation was he had a LASIK complication with scar. So he's 2020. 8 years later, he came for cataract. Now that his cornea is clear and measurable, we put in a toric lens, brought him back to 2020. So again, our desire does not decrease. Here's a patient with a diffuse in-corneal herpetic scar with cataract. Now again, sounds complex when this patient was brought to me. Patient's a physician, herpetic scar, diffuse in the cornea, and cataract. What would you do? Of course, knee-jerk reaction, triple procedure, cornea, cataract, or dog cataract. My point. Again, least interventional. Let's aim for vision. He surely needs cataract surgery, no brainer. Point here. I've written in some of my articles, I call these outside in, inside out techniques, meaning you cannot do cataract surgery on this patient without first making the cornea measurable or sensible, because then you're entering with inaccuracy and you're doing the cataract blindly. It does not help the patient. If the other way around, we'll talk about also inside out, where you remove the cataract to manipulate the cornea, make it myopic, and then come back and do laser to the scar. So in this case, we followed the in-cornea laser to make the cornea measurable. Patient was extremely happy with improvement. And then we went for cataract. And even with here a monofocal lens, brought her to excellent vision, which is what she deserved. So you can see here the in-cornea scar has been cleared. You can still see some residual scar. The astigmatism down to 0.1 diopters, and then we did cataract surgery. So again, patient remembers corneoplastic, 4.5-minute laser surgery, about 7 to 8 minute cataract surgery, topical both a month apart, eyes intact, no one entered, there is no weakness, patients at 2020. Here's the Black Hawk pilot. This case was fantastically corrected. This was actually a stem cell tumor in this patient on the limbal area, which was very nicely corrected by esteemed colleagues of ours. And then he was referred to me with this scenario. So here he is his final outcome, having healed from the amniotic surgery and the stem cell surgery. Black Hawk pilot with 2200 vision, best corrected. So here again, this is on-cornea scar. If you look at this topography here, you see the astigmatism is over 5 diopters, and it's not real. So we took this patient, peeled off the scar under the laser, followed by myopic laser to 0.4 diopter astigmatism, 20/20 outcome. Patient just remembers the 4.5, 5-minute surgery, back to 20/20, back to his profession as a Black Hawk pilot. And there again, you can see how the PENTACAM helps you understand and also help the patient understand vocally and visually where we are headed and why. And you can always explain, like I said, the backbone of ethics and safety. You can always have a transplant with Smith, but I think this is the process we'll go through to get it in the least interventional way, and they get that planned portion. Here's a patient who had a stem cell disorder with this kind of pyogenic granuloma in the limbal area. Patient is a baseball coach, minus 9 diopters myopia in the other eye, was obviously high myopia in this eye equally, but at this point was unmeasurable. Now this case we did in collaboration with Dr. Singh. He did the amniotic surgery and sent the patient to me for refractive correction. So you see a beautiful surgery done here, the amniotic surgery reconstruction. Cornea became more sensible, measurable. I remember this patient went all over the country and was told transplants, stem cell and transplants, artificial cornea, everything. But we planned it out, decided again, least interventional, topical process, even if staged. So once he healed so well with the amniotic graft and the cornea quietened down and was measurable, I put in an ICL for this patient. You can see the iridectomy, an ICL. And this patient came straight to 20/25 uncorrected vision. So again, coming from over 2400 vision and this kind of appearance to here, it's just our own mindset over the patient request where we want perfection is what I'm going to stress tonight. So left side we did the ICL, came to 2015. Now, yes, being the type A desire that I always have, I would still want this area also to be cleared with the laser, but the patient was so happy at this point. 2015 in his left eye, 2025 in his right eye, uncorrected, coming from -9 and from that misery of their appearance. He wanted to just enjoy and be himself. So we left him at that. And here's the topography and the PENTACAM appearance of how this patient moved from very high astigmatism, which just falls because of all that conjunctiva and growth, bring him to a measurable cornea, and then putting an ICL, as you can see here, straight to hemetropic outcomes. Intacts. Microsegments in the cornea, whether you use intacts, Ferrara rings, and various other aspects that we can use abroad too, I believe they are systems of stabilizing the cornea, but intelligently manipulating astigmatism. So I will come to this point again when we talk about lamellar keratoplasty. Intacts, I feel, can stabilize a weak and unstable cornea, let's say in these cases keratoconus, LASIK ectasia, and the placement of these braces, if you may, must be intelligently applied to also correct astigmatism as we go on. And these patients can be brought to 20/20 outcomes. So I call these asymmetric because many a times we use thick and thin intact and decide where to move the coma and the cones in these patients to make it again more measurable. We'll talk about this aspect in another extreme case where I use this for scars, and we'll come back to how I'm always about making this 11 feet tall person somewhere close to 6 feet. Intacts are not accurate, but they can bring you close to normalcy, meaning these patients can now wear contacts or glasses like normal people and function. So I tell these patients, you're 11 feet tall, I'm going to do something for you to stop you from going beyond 11 feet, put intacts or braces in you, which also strengthens your cornea, and then I'm going to bring you closer to 6 feet. I'm not sure if you'll be 5'8" or 6'4", but at that point you can go to the mall and wear a suit. In other words, you can get a normal contact or glasses. Many of these patients sometimes even see good enough without glasses. And you can see the placements. You can again educate the patient post-operatively, showing them with the PENTACAM the application of the intact, the changes in the refraction, and the astigmatism correction. Here's a patient with post-ALK. ALK before the LASIK days, was done a lot for hyperopia, some for myopia, where a microkeratome was used, as you can see here, and the cornea was allowed to go into controlled ectasia to correct the refractive error. This is a one-eyed patient with severe ectasia and very poor vision, 2400, astigmatism of 10 diopters. So given that he was one-eyed, instead of doing a lamellar transplant, I said, let's go to a procedure that is reversible, even though I don't want to reverse it, and let's see where we go. So when we did that for him in a planned fashion, his astigmatism moved from 10 diopters to 2.7. And he was already at 20/40 uncorrected vision, extremely pleased. And again, remember, he's one-eyed. He's stronger now than weaker. And we did a brief topical surgery again, corneoplasty. You can see the ectatic cornea, thin cornea, and you can see the stabilized cornea with the intact and correction of astigmatism. Here he is. If you see the topography right here, this is the post-op, 2.7 diopters, the pre-op 10 diopter astigmatism, and the cornea looks more regular if he ever wanted to go into contact, but he was just happy doing nothing. Now, once you've done the intact for these patients, whether it's ectasia, LASIK ectasia, or keratoconus, I think of it this way. The braces are already stabilizing your cornea and making it strong. Now, most of these patients have residual astigmatism, and we can correct that with laser PRK with the intact in place. And that's a fantastic technique. Improve these patients, remove least amount of tissue, because the laser for astigmatism removes the least amount of tissue, still gives you a large optical zone, which is great for these keratoconic patients. And you can actually see how you improve them from astigmatism 3.7 to 0.3, like in this case. This gentleman had his intact brace somewhere else, was unhappy because visual outcome was what he was expecting. Well, with his intact so nicely done by his surgeon, all I had to do was laser PRK on top, moved him to 0.3. He's very happy with his vision of 20/25 uncorrected. Here you see how the intact single segment in ectasia can bring the posterior elevation down. And again, how you can play with the optics to manipulate vision. Here's this patient with the LASIK ectasia. You see this patient with 7.4 diopter astigmatism. And here the patient with 0.6 diopters by placement of intact. And again, when you show these to these patients, they get it. That your keratoconus or the LASIK ectasia is not going to see 20/20 with one surgery. Let's bring you more towards normalcy. I call them bringing them closer to the end zone, and then you're going to hit it out of the ballpark because we are that close to accuracy. And patients really understand that and become your team. Another case of LASIK ectasia, again, patient extremely unhappy with their surgeon. This can happen, but this is a devastating complication. With the PENTACAM, you teach them what's going on. Of course, there are various lamellar keroplasty techniques, which all of you know and should know, because as refractive surgeons, you must know all levels of lamellar surgery in the cornea. And here we have OCULUS, anterior barrier anti-torque suture, a deep anterior lamellar, posterior, various kinds of posterior transplants. Now, as opposed to intact, in lamellar keroplasty, here's what we are doing. You're adding tissue, and you are keeping the astigmatism really the same because you aren't really correcting any intelligent shape. All you're doing is removing the central thin area with scar and adding a thicker donor to that patient. By adding that thicker donor, what you've done is move the keratometry from 58/63 to 40/44. So the average keratometry decreased more to normal, which is great because you flattened the cornea. And with my 5S system, you actually achieved a lot in this patient. So this patient not only had ectasia, they had central scarring, unstable cornea, and thin cornea. Now, instead of doing a PKP, by doing a lamellar surgery, you remove the scar, you added more tissue, you decrease the keratometry, you haven't treated astigmatism. But guess what? 6 months later, you remove the stitches. Go back with laser PRK, get your astigmatism on this patient because it's a normal cornea at that point. What does the patient remember? 15-minute lamellar keroplasty, again 4-minute laser surgery 6 months later, and they go back to 20/20. That's important. So not only was this patient was going to sue his surgeon and unhappy with this devastating complication, he is back to where he wanted to be without glasses, 20/20. That's again the concept of planning and using the PENTACAM towards your plan or walking with it, if you may. And here's the patient with that lamellar keroplasty after suture removal. I mentioned to you in the intact scenario that I've taken this now to cases of scars, and I'll tell you why. Here's a patient. This is a young man, a 19-year-old man with a pseudomonal scar from contact lenses, dense, central scar. Now, what are the options? When we look at them with the PENTACAM, you will see the cornea is not really that thin. It is centrally affecting vision, absolutely it is. And maybe in this case, a lamellar keroplasty makes sense. We could not afford the laser surgery, and if we did laser, it's dense and full thickness in the center, so it does not make sense just ablating without intelligent refractive input. So these corneas, I call them insensible or non-measurable. Since we could not measure, let's do something to make it measurable. So my discussion with the boy's parents were, when he traveled to us, was, yes, I can do a lamellar transplant, but let me do intact, because I've done it in some cases where the intact, by going in, stabilizes the cornea, stretches the scar, and we know a scar on stretching becomes more transparent. And at the same time, if it does not work, if that ever happens, the intact channel will become my lamellar starting point. They understood that. They understood it as a least interventional surgery, so he can get back to sports and life. And we proceeded. So we did the intact. The scar actually became much more transparent, if you may. You can see by the stretch over here. And here's the important thing that the patient also got to see. Here you see that full thickness scar. That's why we did not do laser. Here's the intact. The scar is still there, but becomes more stretched out. And here is what happens. If you look at the PENTACAM now, his astigmatism that was 7.1 and irregular, you see this complete difference in step as far as keratometry here, nearly 35 to 45, maybe 10 diopter step here. The 7 diopters measurable irregular astigmatism. I call this unmeasurable cornea. By putting the intact, we make this cornea scar into a regular bow tie astigmatism, measurable to 2.2, correctable to 20/25, uncorrected 20/40. This patient came from 2400 vision to uncorrected 20/40 vision, thrilled with his vision, 11-minute surgery with the intact, no need for lamellar or transplant, back to his life, and I gave him the option. Now I could do laser on him if he wanted, because I can measure, or he can wear glasses or contacts to come to 20/20. And the patient is looking at that option, but again, the discussion here is least interventional, topical, brief, visually promising, aesthetically pleasing, and how you can use the PENTACAM technology to walk through this case. Again, you see here, thickness has not changed much because we didn't do anything to the center. Intacts are placed here. Astigmatism became more intelligent or measurable. Refractive defect. Now, you can call it DSAEK, DMAC, PDAC, absolutely call it anything you want. I call it simply endothelial keroplasty because that's what it is. And we can split all the names, and that's great for our academic interest. For the patient, I want hematropia. When we do these surgeries, plan it in such a way with your own results. Plan or measure your 20 DSAEKs or DMACs or PDACs and see what you induce refractively. Many cases now with DMAC are refractively neutral, which is great, but still aim for some myopic endpoint in these patients because you don't want hyperopia. So refractive defect to me is placing the transplant in such a way, the posterior lamellar endothelial transplant, that you can even plan cataract surgery with confidence and put in a toric lens to hematropia. Once again, making the cornea measurable with least interventional, going inside and doing an intelligent or measurable cataract surgery. Epikerophakia, one of those cases where when the doctors refer these patients to me, the name itself paralyzes them, and I get on the phone and I repeatedly try to explain, it's okay to name it, but let's finally look at this giant. What is this giant now? Epikerophakia is nothing more than a donor corneal lenticle sitting on this cornea. If you use my 5S system, this cornea is thicker than normal, it's got a scar in the center, it has a shape anomaly, and it needs correction in the center somehow to bring the refractive error to 0. So this patient was actually a myope of about -15. He had epikerophakia 20 years ago with a brilliant surgeon, and now he wanted help. And at this point, he was, I think, -6 measurable. Remember, you can refract through the scar. He was a -6 myopia with -1 diopter astigmatism, correctable to 20/25 with that correction. Here's what I told him. If you look at your PENTACAM, the cornea is thicker than normal. We know that because that's FEK. And the inside of his eye is perfect because no one had gone in. And all I need to correct here is your myopia and astigmatism. And in fact, that ablation pattern will help me also get your scar. And here's the best part, Mr. Smith. While I'm doing that, I'm not even working on your cornea. I'm working on somebody else's cornea on you. How safe can that be? Because if it doesn't work, I will do what your surgeon flew you to me for, which is to take off your epicardophakia. You can always remove an epicardophakia. As I've said always, a LASIK flap can be lifted to eternity. Cornea, lamellar, never heals. Once you find your area, it will always come out. So, but again, least interventional, give credit to the previous surgeon and take the patient to hematropia. So in this patient, having told the patient that we are working on somebody else's cornea on his eye, if it doesn't work, I will peel off the epicardophakia, which is why he has flown to me, but I think going this way, you will get his vision. And we have enough cornea. So we did a laser myopic PRK, brought him straight to 2020. And again, patient is happy, flew back, great relation with his surgeon, back again, and he got what he had started 20 years ago, hematropia. Another case of epicardophakia. This is a patient who was 65, 66 years old. Now here, if you see the epicardophakia, it's decentered, kind of a scar in the center. Difficult to measure, and she's aphakic. This is an aphakic epicardophakia. Many of you, of course, know epicardophakia. It was done in an era when intraocular lenses were not available widely. So they used to do this after removing the cataract. So this would help them see. Now, remember, in my 5S system, this is actually stronger than normal, meaning a thick cornea. Second, it has scar because in the middle of the pupil. 3, it is so irregular, I can't measure. Once I cannot measure, my first reaction is, how do I make sense of this cornea? Now, remember what I just said, every FEK can be peeled off. 17 years after her surgery, we went in and I found the area, we peeled off her FEK, intact Bowman's underneath, beautifully done surgery by her surgeon 17 years ago, and now she's purely aphakic. You go in, put a secondary lens, whatever kind you want, anterior, sulcus supported, sutured, glued, IOL. The point again is, 2 surgeries, a month apart, topical, brief, aesthetically pleasing, visually promising, least interventional. And he brought this patient in her late 60s, the end point which she had dreamed about 17 years ago. Again, if you see, I don't care of calling this epicardophakia. I'm just describing this giant as a little dwarf with basic issues. Thicker cornea than normal, scarred in the center. I cannot measure your cornea. I don't know what lens to put in. Now, those 4 become my pins. And when I get ready for my strike, I want the least surgery to harm the patient. I want the maximum vision to benefit the patient. So we removed the epicardophakia lenticle, came back, did secondary lens. Here's a patient with LASIK ectasia with epithelial ingrowth and cataract. Now, again, the mindset. When this surgeon made this patient travel to me, again, the notes were extensive, lots of OPDs, OCTs, PENTACAMs, you name it, all the testings, all the topographies. But to me, that's not important. Looking at the patient, here's my 5S system again. The cornea is ectatic, so we need to do something to strengthen it. That's pin number 1. The epithelial ingrowth is bang in the center and pretty big, so I have to remove it, pin number 2. Pin number 3, I have to at some point do the cataract, but I'm not going to do the cataract until I can measure the cornea for an accurate lens implant. With these things in mind, and you want to give this patient hematropia to her endpoint. That's also important. Of course, my pictures are giving away my plan, but let's think through. So, doctor, why don't you do a lamellar transplant here because it's ectatic. It has a central scar, and you can decrease the case, control the ectasia, and get rid of the scar. Well, because again, remember my other sentence I told you, maximize vision with the least intervention. Even lamellar is interventional in this case. And I have to go after the epithelial ingrowth under the LASIK flap. So for some reason, I have to pick up the LASIK flap. While I'm there and getting my epithelial ingrowth, I decided to tack down that whole LASIK flap in a manner that is turbo-guided under the microscope. And you can see the stitches that are placed in such a manner. This is the hinge of the flap. After removing the epi ingrowth, I've stitched the flap down and very gently and carefully take the stitches in a manner to neutralize my topography as much as I could. And let the patient heal. That did 2 things. I kept her waiting for 6 months to look for any recurrence of epi ingrowth, which does not happen once you suture the gap. 2, to measure my cornea and see if it had become sensible. Lo and behold, I could measure the cornea. I could be very accurate with the IOL master. I could decide what lens to put in, plan for it. And I did not remove the stitches here. What's the need to remove the stitches if the cornea is stable, measurable, and hasn't changed, and giving me my optical intelligence to enter the eye fully armed for emetropia? So I left the stitches, performed the toric lens in this patient, brought her exactly to our vision endpoint. And here you can see the pattern, the epi ingrowth here. Epi ingrowth is gone. Show the patient the next stage, their cataract here. And now that your cornea is more measurable, as you can see here, I'm now going to go and do your cataract surgery. And from there on, you proceed. Majority of the patients who seek me, many of these patients without being referred just fly and travel because they're very unhappy having had and paid for premium surgery with their surgeon and are extremely unhappy despite good surgery. Majority of these patients are what I call half done. Their astigmatisms and residual refractive errors aren't corrected. I cannot stress on this more, cannot put in any technology in the eye that is supposed to work with perfect optics and leave any astigmatism in the cornea. I've been asked this many times, and I say this in a very straight sentence. To me, my toric tolerance is 0. There is no such thing as minus 0.6 or minus 0.75 astigmatism, and when should you treat, when should you not treat. Refract the patient, stimulate their vision. If to them that minus 0.45 astigmatism is irritating and causing symptoms and all this anger, stimulate it, give them a stimulation. If they improve, proceed. Proceed with laser on their cornea, make their doctor look good, make their surgeon look good. The lenses that they put in the eye start working perfect, and the patients are extremely happy. Again, 4.5-minute laser technique done with all their misery ended. The lesson here is, please run the topographies before surgery. Make sure you're not missing diagnoses like keratoconus, abnormal corneas, astigmatisms in the cornea, anterior and posterior. Now, with the confidence we had with doing so many RK patients and bringing them to emetropia, we took it to the next level about 15 years ago, where I've even done multifocal lenses in these patients, and the majority of these patients were doctors, engineers, bankers, people of pretty high IQ that they would complain if they had some issue with their visual endpoint. The confidence again came from the results, but also from analyzing using technologies like the PENTACAM, and again, visual vocal education for the patient. Here's your cataract, here's your RK. I have a double issue to take care of. Let's first make your cataract surgery in these patients, turn them myopic astigmatism, and then come back with laser, correct the central cornea, increase the optical zone, bring them to emetropia, and voila, they actually see distance and near, and all of them reported excellent night vision. And if you can see here the laser part happening, cataract to multifocal lens, to laser, astigmatism down to 0.3 from 1.2. Again, finish the job. And the patient gets it when you show them this stage. They're excited to go to this stage. They're very excited to come out here. Patient with corneal scars with RK. Again, to me, every scar is refractive. I'd never look at a corneal scar and go, there's a culprit, let's cut it, let's remove it. I always look at it and go, how do I tame this guy and get my vision? Now this cornea, if you notice, is on-corneal scar. Look here in the corneal densitometry picture of the PENTACAM, and you can always feel it on epithelial removal. The on-cornea scar was preventing me from measuring for his cataract. Very demanding patient, extremely knowledgeable, had read all the things I've ever written, came in with intelligent questions. We sat down for 2 hours and made a plan. Plan was to remove the scar. We peeled the scar off. You can see the post-op corneal densitometry here. Scar gone. Again, I'm not interested in total scar. I just want my shape and clarity and measurability of the cornea. The cornea is clear. Within minutes, proceed to toric lens implant in this RK case, straight to 2020. My point again, we simply broke this giant of a scar, RK cut, demanding patient, cataract, wanting emetropia. Break the giant down. Can I measure my cornea to enter the eye? Do I have the right to enter the eye without knowing a proper lens evaluation or measurement? We went outside in technique, did the cornea, cleared it, made it measurable, went inside, did the cataract, brought the patient to emetropia. And I like to always show the patients because to me, there is no higher level of documentation than a patient who has paid for his procedure. And these are demanding, very demanding patients, and I love to show their immediate reaction because they become part of your team as they progress in this team play towards hematopia. Here's a patient, again, a PhD, very intelligent gentleman, came with this appearance. He had a herpetic corneal scar, and here you can see a divot, actually. It's in the center. It's a central divot here. So patient had 13.5 diopter astigmatism, which I don't believe. It is a immeasurable or improper representation of this patient's cornea. You can see the scar, actually, it's a divot here in this cornea. Again, I don't care for that scar. I started refracting this patient. Couldn't refract. All the refractions came down to very unattainable, if you may. So what do here? I take this patient, do a laser scar field to clarity. Again, you can see the residual scar here. But look at the clarity. Patient actually became 20/30 from 2400 uncorrected. To the point he was so happy that he said he will wait for his cataract surgery, and he went back to his life. So you can see the scar, the residual area still there, but the patient is uncorrected 20/30. This is the herpetic scar. Patient came in for cataract surgery, and when I measured him, I wanted to see why is he happy. I can still see the residual area. Why is he so happy? And he's such an intelligent person. You can see here the depiction of his vision and how much it improved by taming the scar with the laser. You can again see the silhouette of the scar. Here, I planned for him a stage cataract surgery. I wasn't too sure of his measurement of the cornea. The IOL Master and other machines did not give me any accurate measurement of the lens. And again, you don't want to go in and change lenses and stuff like that. You want to be very elegant, least traumatic, more driven to vision. When you explain to the patient with the PENTACAM, they understand. Here's the residual scar. I'm not getting a proper reading. Let's plan a stage technique. I'll do cataract surgery. I will not put a lens in. I will measure you in a week and then put in a lens that I think is more accurate. So when I went in with this patient, I also chose the femto laser technology. Again, these are other discussions, but I use technology only to the patient's advantage, never unnecessarily in any patient. In this patient, I could not afford to have a rexus, despite thousands of rexuses we've done, to have any variance in what I really wanted. I wanted a slightly decentered rexus of an exact 5 millimeter size, and I wanted it to be perfect, so I don't have to think about that step as I plan my next step, which is how to put the toric lens in, perfect online. So we did this patient femto laser, brought him to aphakia first, and then put in a toric lens and brought him straight to emetropia and 2025. Now remember, you can still see the silhouette of this scar. It was herpes. Here's the gentleman, and he's 2025 uncorrected and thrilled with his outcomes. There's another patient. This patient was flown to us from Switzerland, keratoconus, congenital cataract, high myopia, high astigmatism, young lady having a very brilliant career in front of us, but frustrated that she couldn't wear contacts, and what does she do now? Remember again, when I look at this case, it is not to get overwhelmed. That's the first lesson. I pick my pins. It's keratoconic. There's a cataract there, even though it's congenital and small. Extremely high myopia, high astigmatism, thin cornea, high keratometry. Young patient. What am I going to do now? So if I look at all the defects, I do see the cataract is also causing an issue. I show the patient a thin cornea. And even though the cataract's early, remember that statement. You don't want to do a mediocre job for another surgery to come up for no reason. Patient's coming in, she's having surgery, spending time and money. Let's do it with the future in mind. After I sent her to our retina doctor in town, got her cleared, made sure the retina was perfect, no need for prophylactic laser, went in, removed the congenital cataract. But before that, I had to plan to make the cornea measurable. Here, what I did is I first put in intact, as you can see here. Made the cornea flatter, more measurable, astigmatism more measurable and regular, and you can see in the topography how things improved. And now my plan was the lens. Now I went after the lens, removed the congenital cataract, and you can see even a toric lens. The confidence to put a toric lens in these cases comes from the fact that your initial step was successful, so it led to this step of further success. That's very, very vital to me. You cannot plan stage surgery by doing it and then hoping to land somewhere. It has to be planned for a stage. Next stage is end zone. So when we put a toric lens, brought it to 2020, same patient still has keratoconus, but now she has unaided 20/20 vision in both her eyes as we did the same process 3 months apart. And here's the patient again, intact first, followed by toric lens, back to Switzerland, back to her life. Now, there are certain patients who are also prone to me with situations where the doctors go, Dr. Gulani, can you please do this and this? And I go, all right, let's first take a look. Again, remember, I always plan vision, not surgery. Surgery is my coincidental pathway to manipulate optics. My whole aim is vision, how I talk through with the PENTACAM, how I show them what's happening, how I make them the team player, and decide what to do. Very demanding patient again, was flown in, had traumatic mydriasis, as you can see here, with cataract, and wanted perfect vision. Here again, my decision was I could surely do an iris suture circlage on this patient, but wait a second. We're aiming for perfect vision. I can't afford to have a CME or any iris, iritis, anything in this patient. Second, luckily when you do such deep thinking, things work in your favor. This eye turned out to be non-dominant. Now our other eye was 20/25, remember, uncorrected. So this eye, I told her it's a non-dominant eye, and you have some botheration of lights coming in this eye. Let me make it a monovision concept where I'll put in a toric lens and I'll use a femto laser so I can use my rexus for about 4.5 millimeters so the capsule can opacify and become a pseudo-pupil and decrease your light in the near future. And I will correct you to monovision, meaning I'll make you a -1 in this case. I simulated that for her. And this eye will be more for reading. I had two things on my mind now, two things on my shoulder actually. I had to first perform this exactly like I said. So I used the femto laser for the ability to do the rexus exactly how I wanted. Put the lens in, made her -1. You can see the perfect placement here. And then within 2 weeks, I did a clear lens exchange in her right eye, brought her to 2015 vision. So that eye became super good for her. And now she could use both eyes. I was extremely pleased, no need for circlage, back to her surgeon, and happy with her outcome. Certain cases, you can flip the axis by using a toric lens in these cases, because the laser, for example, the one that I use, uses a flat axis for astigmatism, and then play with that. In other cases, you can correct the corneal astigmatism from 7.9 to 2.4 by making it regular, and then put a toric lens and bring them to emetropia. Again, it's not the scar, it's not the RK, it's not the 5-6 LASIK they may have had. To me, it's the refractive endpoint, guided by topography, guided by the measurements, guided by the safety, and we want to keep our 5 filters to emetropia. Here's a case that I would like to end with. The patient was referred to us, 73-year-old female, had a restored multifocal lens put in. Patient had I was surprised, hyperopic. Doctor kept performing LASIK, laser, PRK, ended with a scar, high hyperopia, mild astigmatism, and very poor vision. Best corrected, it was 2200. Patient extremely unhappy, wanted to sue the surgeon, and also the doctor had done a YAG capsulotomy. So remember now, my pins. I don't care how horrible this looks. My pins are, lens is already in, surgeon has tried the best they could, and the bag is open, so you don't want to exchange the lens, and you want to do something to make her measurable inside out or outside in. Here, because I can't measure the cornea because of the diffuse scar, I first did a scar peel, brought her to clear cornea, measurable. Now I could measure her refraction. +6 -0.5 into 170. And she actually corrected with glasses 20/25. Now I had a second stage issue. Now that I have a clear, measurable cornea, I could intelligently enter the eye, but wait, I'll have to remove her restored lens, meaning vitrectomy, meaning CME, meaning other high surgical intervention. Surely we have the skills to do it. Point is not to go there unless we have to. So make her surgeon look good, leave the lens in place, and I decided, now that your cornea is measurable and you have +6, I'm going to do a piggyback lens in you. I will leave the nice lens and surgery that your doctor did, and I'm going to put in a piggyback lens. That's what we did. Brought her to 20/20, distance and near, final refraction, uncorrected vision. Patient is back to where she had dreamed to be. Relation set for the doctor and the patient. Patient fly back, travels back. Point again, topical brief surgeries, scar removal, piggyback lens, back to emetropia. So the concept, when you show the patient, you show them the movement you're going through, the planning you're doing using topography, visuals like the overview, I think are very vital to educate and bring the patient to summaries of treatment. And then themselves become excited, energetic, and becoming a team with you as you convert these not a candidates to excellent vision. Here's a summary of her situation, scar clearance, piggyback lens to emetropia. Thank you so much for your attention. I'll take the questions now if you have.
Thank you very much, Dr. Gulani. Real quick, there are a lot of questions, and I'm going to get to those in just a second. Before we do that, I'm just going to let everybody know that this webinar was recorded, so if you did not watch the entire webinar and you would like to see it, we will have it posted on our website at www.oculususa.com, and we should have that on there in about a week. We also have other past lectures you can get to on our website, oculususa.com, as well as oculustv.com. And then if you have any questions, you're welcome to contact us here at Oculus with the information that you can see on the screen. So again, thank you very much, Dr. Gulani. A very impressive presentation. I do have quite a few questions here. So in the first case that you looked at, in case 1, are you not concerned about doing PRK on a cornea with keratoconus?
Very good question. So again, please remember, astigmatism removes the least amount of tissue. Myopic, in this case, we brought him to -1 diopter. Total tissue removal was about 19 microns in a patient who was 68 years of age, so they are basically naturally cross-linked. Of course, there are studies that have shown some patients progress even beyond that age in keratoconus, but remember I told you the patient's surgery was done over a year ago. Refraction has been stable for the last 7 years on the cornea, and all those parameters are important to take into consideration. Once the cornea is stable, patient is over 68 years of age, naturally cross-linked. I'm doing a very minimal 19 micron surgery on this patient. There was little concern, and here's the other part. If I feel he's changing, I can always cross-link, but now need to do it now. At this point also, he's been very stable. I will follow up. So yes, you can cross-link these corneas if you want, but doing these cases with those parameters does bring a safety net in these scenarios.
Okay. Next question here, and we may not have enough time to get to all of these. It's an unprecedented amount of questions, which is a good thing. But this doctor asks, I would imagine that most of the patients with corneal scars who have 20/400 vision don't refract to 20/20 preoperatively. What is your advice on getting the right refraction to program your laser? Do you just use conventional PRK on all of the in-corneal scar patients?
Yes, please. Now, remember again, refraction is the key to all of this. Even though I have all the topographers, all the OCTs in the world, refraction is vital. That's why the most important thing I may stress on all of you tonight is please look at every corneal scar as a refractive surgery, to the point that when my fellows are looking at these patients, I refuse to let them think transplant. So, as long as the mindset is that clear, now here's how I approach it. Whether it's in cornea or on cornea, I first take my street retinoscope and start refracting. If I can make sense out of it, that's my refraction. Many of these patients, you'll be surprised you can refract them down to 20/30, 20/25. And if you see my algorithm, and I'll be happy to send you those articles, of corneal scar, if they're improving by refraction to 20/40 or better, proceed with laser 1 stage, straight PRK. If they are less than 20/40 or better, do a hard contact lens trial. If they now improve to 20/40 or better, do a 2-stage laser, where you will remove the scar field, and the next stage, measure the cornea and proceed with that refractive endpoint. So that is the way you proceed in the protocol of corneal scars. But surprise yourself that many of these patients actually can be refracted down to 20/20, 20/25. I repeat, none of their vision quality is as amazing as a virgin cornea 20/20, but to them, when you refract them, they start smiling with you as you go through the phoropter. That's a very powerful scenario, and you have to replicate that when you perform surgery.
Okay, thank you. Here's a question regarding the PENTACAM. And I'm sure you won't have any trouble answering it, but I can help with this if needed at all. How do you tell by looking at the PENTACAM whether this is a on-cornea or in-cornea scar?
Great. So the question is, how do you know by looking at the PENTACAM, is it an on-cornea or in-cornea scar? When you look at the PENTACAM, first of all, look at the topography. If it's bizarre and the astigmatism is all over and the keratometry is all over, meaning I call it a clown suit, so you got the idea. It's kind of, the waist is 40 when it should be 20 or 30. When the height looks like it's 11 feet, then it should be somewhere 8 feet. You know there's something wrong. 2, there's another window in PENTACAM called the corneal densitometry. That's great. You get the profile of the cornea horizontally and vertically. and you have a way to measure the depth of the scar by clicking on that number 2 section there. You can actually move that red line down to see the depth of the scar. 3, when you look at it as a tomography, you can actually see the extent of the scar through it. Now, of course, you can use OCTs with it, but I'll tell you the acid test for me is on table, when you remove the epithelium, while removing the epithelium manually, when you hit against the scar on the Bowman's, that's on cornea. When you do not hit the scar and you're just getting a smooth Bowman, that is in cornea. That is the $1 million acid test. But with the PENTACAM, you're over 90% predicting what you will find in surgery.
Okay, thank you. So this is kind of a half comment, half question. So this doctor is asking a straight PRK scar in the cornea. Can you please explain the procedure? Is mitomycin C used?
Yes, please. So number 1, please use straight PRK. I do not like wavefront guided or topo guided techniques in these cases because both of them are way off. You're not treating the mountains and you're treating the molehills if you do that. So straight PRK, don't change anything in your technique. The beauty is in the epithelial removal, which has to be manual. That's the excellence of corneal scar removal. 2, do PRK with mitomycin. Yes, please, all the time, 30 seconds, and flush with BSS. And if you see the videos that a lot of my videos out there, when you do the BSS on these patients after removing the scar, you see a perfect circular reflex under the laser, and the patient literally starts crying or smiling that they can see. That is the most powerful feedback of scar clearances with laser that you'll ever see. So no change in your PRK technique at all.
Okay. So I think if you want to take maybe just a couple more, and then I think we'll call it a night. And then what I can do is I can maybe forward some of these to you if you like, and then you can answer them at your leisure. And some of them I think the staff here at Oculus can handle as well. So where does corneal cross-linking fit in with the patient who has ALK and ectasia? Would you consider it before or after the NTACs?
I always consider cross-linking to be the end point of every keratorefractive surgery, and it should be. So think about it this way. When I'm teaching, this is the language I use. You have somebody with kyphosis, right? A bent back. I'm talking about keratoconus. Now, just because a new cement has been released doesn't mean you start cementing that bent back so it doesn't bend anymore. That to me does not make sense. Why would you cross-link a keratoconic cornea or an ectatic cornea without first correcting the shape? So to me, I would first straighten the spine by whatever technique I have to, laser, intact, or lamellar, whatever. Correct it and then cross-link it. So literally in all the cases I discussed tonight, you can do cross-linking as an endpoint. The point is it is not needed in most cases. So, but my take is always cross-linking after correcting the corneal shape, which equals visual endpoint.
Okay, so, and then I'll just finish with this last one. Give me 1 second, I had one here that was... Is it possible to visit Dr. Gulani's office to see some of these surgeries in action? Oh,
you
Dr.
are welcome. We do have yes, please. It's the question regarding coming over to visit and see the surgery. You are welcome. We do have a wait list with people applications. There's a channel to do that. My office email is gulani.com. Please email and we'll surely help out. Also, a lot of these videos we are now keeping ongoing in iTubes and YouTubes so people can see. And of course, constantly talking and teaching about this because I'm so excited to have found this concept for scars where it will change your mindset that even a normal myope, when you treat, you'll be thinking about maximizing their vision, not just taking their glasses refraction or your technician's refraction and going in, but actually refracting the patient, tuning them down to 20/10, and then feeling proud of the endpoint. So when you look at it from that angle, if tonight I have managed to just at least stimulate any one of you to look at scars and irregular corneas, so-called irregular corneas, or all these complex cases that there should be no word like complex in medicine. Each case to be taken uniquely. Perfection has to be in your mind, least interventional and safety for the patient, and take them to hematopia.
Thank you very much, Dr. Gulani. It's been an honor having you. It was an excellent presentation. And for everybody out there, again, if you did not catch all of the presentation, we will have it on our website. You have the information there, and you're welcome to email us. And I wish everybody a good night. So thank you.
Thank you, Chris. Thank you, everybody. Good night.